So, according to my Greek colleagues, I think I can say kalispera. So I want to thank the organizers and for the invitation, and of course all the team in Lyon that I work with. And I would like to thank also all the listeners here and abroad for their privileged attention. So we've had great talks about temporal lobe, insular lobe, and now we're gonna go to the frontal lobe that will occupy us tomorrow, and I'm very honored to make this last speech of the day. Historically, the second case of Sir Victor Horsley was quite close to the fronto-opercular cortex, although as you can see, there were cramps in the thumb and forefinger, so probably he was a little bit above. But actually, the surgery took out a tuberculoma at the junction of the lower and middle third of the frontal parietal convolutions, and the patient was cured. Then the second case we found was in the series of tuberous sclerosis patients published by the Montreal group in 1966. And in this paper, there was a young girl, 5-year-old girl, who had uncontrollable bursts of laughter followed by twitching of the right side of the face. And she was cured by the removal of a portion of the precentral and postcentral area of the face, which was compatible with the tumor. And so the first case that we actually found, there was a resection that was restricted to the fronto-opercular cortex, was one of the cases of Obana in 1992. And that is the description of the patient: epigastric sensation going to the throat, followed by choking, drooling, and an inability to speak. And he was cured by a resection of a left fronto-opercular lesion. So in fact, when you ask epileptologists about opercular and fronto-opercular seizures, they will tell you symptoms around the mouth: tongue, throat sensation, hemifacial contraction, mastication, salivation, ictal and postictal dysarthria or aphasia on the dominant side. Now, if you ask pediatric epileptologists, they will tell you self-limited epilepsy with central temporal spikes. Of course, and indeed, why would they say that? Can I pass the video? Oops. Can I start? Oh, yes. So you have this patient that's sleeping. He is going to awake, and he's going to have this facial contraction, the lower part of his face on the right. He's going to sit down. You can see with his eyes he's looking for his father, and he has some drooling that is starting, and then he's eventually going to generalize. And of course, these seizures and these patients are way more frequent than the one we're talking about today. Anyway, so, oops, can I pass? So the frontal operculum is that area that covers the anterior part of the insular cortex, and it comprises on the lateral surface lower parts of area 4 and 6, area 44 and area 45, pars opercularis and pars triangularis, that on the dominant side constitute Broca's area, which is the main limitation for surgery in this area. And on the lateral aspect, as you see, usually the functional definition that we have of the fronto-opercular cortex is that goes up to the face representation, and at least the mouth representation, and just to remind that it goes quite high on the lateral surface of the fronto-opercular cortex. Now, as you can see on this coronal slice, of course, there's a lot of deep hidden cortex in the opercular cortex, and it's interesting that there's been a recent research on architectony, and 3 regions were described in the fronto-operculum, OP5, 6, and 7, and they are actually functionally involved in swallowing and chewing, which has sense towards the clinical manifestation that we know. So what do we know about, we all know the main symptoms of these seizures. Well, it probably comes from this huge paper of Banco and Talirac in 1992. They had 210 patients, all explored by SEEG, with a bemol that there was no insular contacts. And they had different groups, 8 groups, and the one with the inferior frontal gyrus is that the symptoms are reported here. So on the non-dominant, they separated non-dominant and dominant hemisphere. And on the non-dominant hemisphere, you could have speech arrest, which is something that we find easily, and elementary motor signs and postural signs of the arm. And they already described salivation, deglutition, and some autonomic disorders. And they said that on the dominant side, they had the same symptoms with more aphasic and postictal aphasia. They also had their insular opercular list of symptoms. They were all gustatory and autonomic sensory regulation, but once again, there was no electrodes in the insula. But they explain in their paper that they make correlation, and they actually were probably right. Those symptoms did come from the insula. Anyway, more recent studies in the beautiful paper of Marseille with 54 frontal lobe epilepsy patients that were studied for semiology. Once again, you can see that we have positive motor signs that are predominant when we are having seizures from this posterior and inferior lateral opercular frontal cortex. So this has been described, this rostrocaudal organization of the motor manifestation, and we're going to see that in the fronto-opercular cortex, we're going to have more elementary motor signs that go from clonic to tonic and postural of one side. So BA4, BA44, you have early clonic signs, contralateral aversive signs, proximal distal contralateral tonic posture, and in more anterior part of the fronto-opercular, area 45, you do have vocalization, hyperkinetic motor behavior, proximal stereotypes that Laura spoke about yesterday. Another important point of that study is that actually in these areas, in this upper quadrant here, you do not have emotional signs, and that's one of the essential findings. Now, in another series with the insular opercular seizures, the group that had a frontal involvement, which is group 3, the signs that actually came out statistically was laryngeal and orofacial manifestation. So everything is quite coherent. So finally, what are the main issues and controversies on semiology? Well, I'm an epileptologist, so the first question is, do we have auras in pure frontal opercular seizures? Any specific? We already know that it's going to be no. Okay. Now, the second point is for surgeons. It's their dream not to go to the insula, so can we do a strictly resection, strictly localized to the frontal opercular seizure and not go to the insula? And the third question will be, when you have complex motor phenomena, up until when, can you ask yourself the question, could it come from the frontal opercular seizure or frontal opercular cortex, or I'm elsewhere, either in the frontal lobe or elsewhere? And we're going to, I think, with this question, and answer at least have part of the response of the question that were asked during the precedent talk. So our search keywords started with the words fronto-opercular seizure, etc. We didn't have any series, no case reports, so we enlarged with other terms up to ventrolateral prefrontal seizures, and we ended up on PubMed plus Ambase on 192 citations. 65 abstracts were reviewed among these citations, 41 articles, and finally, we selected 9 articles, and I think I have the record here. We have 13 patients. So, we were very strict, it's true. We had to have patients that had a suspected fronto-opercular epilepsy. The semiology had to be, we could find it in the paper, and this patient had to be either cured by a resection that was limited to the fronto-opercular cortex, or he had depth implantation, including the insular cortex, or he had suspected fronto-opercular epilepsy and some complementary non-invasive exploration, MRI positive, or ictal source imaging positive. So here are all the papers. So some you will recognize. We have 3 patients out of the 37 of the insular opercular paper, where for 3 of them, they described that the onset was strictly precentral operculum. Then we have gelastic seizures. 2 of them had a lesion in the inferior frontal. 1 was operated and cured. Then we have the Obana cases, 2 cases that are very similar. Then the case of Oslan is very surgical, but they do have a description, and they had a lesion in the frontal operculum. The case of Sato is interesting because, if I don't mistake, there was a very, very important salivation. The case of Fricher is the Marseille case that we put in. where they had this description of a hemibalism on the ipsilateral side and a dystonic-tonic contraction on the contralateral side, and it was at the limit of area 45 that the patient finally had an FCD. There was one patient in the Milan series, the first case, where he was operated strictly in the fronto-opercular seizure, and he had major nocturnal frontal attacks. There was one case of Rini with an MRI negative, and that's the case where we put moderate also because we only had source imaging. She's not operated on, but under treatment she's doing well. And then we have one case of Wong, which is a PET SEEG study out of 22, where once again the epileptogenic zone was confined with the SEEG to the Rolandic cortex. Frontal opercular. So numbers are, as you can see, 69% of adults, 70% of MRI positive, GRID or SEEG, but the GRIDs were all cured by operation. Those operated, 84% operated, and when angle was known, it's 100%. Okay, so we had a very high confidence in the epileptogenic zone. So here are the symptoms. So as you can see, we had all the same symptoms that were described in the insula. Somatosensory, some were visceral sensory laryngeal, some were visceral sensory epigastric, some were autonomic palpitation. What I added here is that we had no patients in these 13 patients with a mixed aura. They had one type of symptom, which is probably something important compared to the insular cases. Now, the elementary motor that we found, orofacial was 30% of patients, and actually tonic or dystonic brachial manifestation contralateral was close to 70%, which is a high number. And complex motor behavior, that we will talk about, was 30% of seizures. Now, we also had salivation. Interestingly, the only cases where there was no loss of contact that was signaled were those with the big salivation. And there was also very few patients with choking, gagging, dry heaving, hyperventilation, tachycardia. The 3 patients with some mirthless laugh, facial distress. And we did have speech dysfunction, 1 time on the left and 2 times on the right, and verbalization 2 times on the left. Okay? So conclusion, auras, yes, there are auras in fronto-opercular seizures. Specific, certainly no, but maybe we can have a little hint when we have one type of aura and not a mixture of this visceral-sensitive, visceral-motor, etc., etc. Do pure fronto-opercular seizure exist? Yes, we know. And to answer the last question, I want to show you 3 short cases with some motor manifestations. Here's a young lady, she's 17 years old. She has an aura with paresthesia around her mouth that is not lateralized. She doesn't always have seizure when she eats. So she can't speak, and she has this facial contraction to the left. She's putting her hand inside her cheek so she doesn't bite herself. Then eventually the clonic movement will go to the eye. She can answer and she can do what the nurse asks her to do. And at the very end, she's just going to choke a bit, and that's the end of the seizure. Whoops, can I stop that? So, whoops, that's too fast. She ended up, after a few MRIs and PET, to have a very, very small FCD right at the top of the operculum, actually at the limit over the operculum, and she was actually cured by a lesionectomy there. So this is to show you like the most posterior and actually quite up type of seizure that we had in fronto-opercular. This is a second case, a 15-year-old patient that had a very specific aura, painful sensation in her right ear, that was followed by a painful sensation in her right arm and a tonic, dystonic posturing of the 4 limbs, predominant on the right, and actually she's going to end up on the right. So bilateral, tonic, slightly asymmetric here. Okay? She had an MRI negative, and she finally had 2 SEEG to finally show that it really started in the F' electrode here in the operculum, the frontal operculum, and the painful sensation had an activity. The sensation here were concomitant with an activity on that electrode, and when she had her short tonic seizures, there was an involvement of the electrodes going to the central areas. We didn't have the cingulate, but the other insula could also go into the seizure. And she's also 1B after a 8-year follow-up with one drug after this limited surgery. And the last patient I want to show you is this young boy. So the seizure has started. He has paresthesia of the tongue and the cheek on the contralateral side. And then this posture of the right arm and of the right side that's quite tonic. And this behavior, that's hyperkinetic behavior on the left side. It's very close, I think, to the case of Marseille with the hémébalisme. And so this is one kind of motor manifestation that we can have starting from the fronto-opercular cortex. And this patient, actually, he had a heterotopia on the other side which had nothing to do with it. Edouard, I don't know if you're here, you know this patient. And he was finally cured by a resection of the fronto-operculum, and he's without drugs for 14 years. So, once again, yes, ORs are frequent. Once again, they remain of tremendous importance when you see this semiology of the motor activity that we see at the end of the seizure in these three cases. They're very different, but if you don't have the aura, it's quite difficult to be sure you're going to go to the fronto-opercular cortex. Yes, pure fronto-opercular epilepsy exists, but difficult to be sure without depth. And yes, complex motor behavior can still at least start in the fronto-opercular cortex, but you will, in all the cases that we've seen, you always have this contralateral tonic contraction at some point, even if you have a very big hypermotor manifestation on the ipsilateral side. Of course, you're going to tell me it's probably propagation, but okay. Thank you for your attention.